Dr. Thwaites is a professor of infectious diseases and director of the Oxford University Clinical Research Unit. Dr. Guy qualified from Cambridge University and the United Medical and Dental Schools of Guy's and St. Thomas's, and trained in infectious diseases and microbiology in Brighton, the Oxford University Clinical Research Unit in Viet Nam, Imperial College London, and the Hospital for Tropical Diseases in London. He has held Wellcome research training and intermediate fellowships and was recently awarded a Wellcome Trust Investigator Award. In 2013, he was appointed Director of the Oxford University Clinical Research Unit and Wellcome Trust Major Overseas Program in Viet Nam. He is responsible for the scientific strategy of the program, with its major research themes of emerging viral infections, dengue, brain infections, tuberculosis, malaria, enteric infections, antimicrobial drug resistance, and care of the critically ill. He is a pioneer in research in CNS tuberculosis, and the Thwaites score is part of evaluation of tuberculous meningitis globally. He will update us today on the recent advances in the diagnosis and management of tuberculous meningitis.
Okay, thank you everybody, and welcome to this talk which I'm going to give about the management of tuberculous meningitis and update. So my name is Guy Thwaites. I work in Viet Nam. I'm director of the Oxford University Clinical Research Unit in Vietnam, which is a clinical research program that exists in Vietnam, also with research units in Indonesia and Nepal in Kathmandu. I'm going to talk about tuberculous meningitis, and I'm going to give you an update on management. It's going to be quite high level because I only have around 20 minutes, but I hope I'm going to highlight all of the major changes and the major pieces of work that have occurred over the last 2 to 3 years in this disease. But before I start providing that kind of update, I thought I'd just give you a quick summary of why TB meningitis is such an important problem and such a difficult problem to manage, diagnose and treat. So you'll all be fairly familiar, I think, with the disease because it's common in India, but it causes 4 particular problems. Firstly, basal meningitis, secondly, hydrocephalus, thirdly, infarction, and fourthly, tuberculomas. And you can see representatives of those complications around this slide, with tuberculomas in the top right-hand corner, tuberculoma and basal meningeal enhancement in the top left, infarction in the bottom left, and hydrocephalus in the bottom right. So it's a disease that carries significant mortality, and certainly in those who present late with coma, mortality is extremely high. It's just worth remembering that this is a disease which has similar or identical really pathology to the rest of tuberculosis around the body, and that the currency of that pathology is the necrotizing granuloma, which you can see there in the center of the slide. So why are we interested in TB meningitis? Why is it a problem that clinicians particularly find troublesome? Well, it causes significant mortality, as you can see here. So this is data from around 600 Vietnamese adults with TB meningitis, and it shows you the survival in both HIV negative and HIV positive. And you can see immediately that there is a significant difference between death rates in those who are HIV infected. The outcome from HIV infected individuals is pretty catastrophic, and it doesn't really matter where you are in the world. About 40 to 50% of people with HIV, with TB meningitis, will die. And if the estimates of the numbers of people with this disease across the world are very uncertain, but a conservative estimate is that at least 100,000 people per year acquire TB meningitis. And if you're thinking of mortalities of around 30 to 40% in those patients, then that is a very large number of people who are dying from this disease every year. I think if there's one thing that I want to impress upon everybody, and I suspect it's not that required for this audience, but I always say it at all talks about TBM, is that you cannot delay the diagnosis and treatment of this infection. As hard as it is, treatment before the onset of coma is the greatest benefit that you as physicians can give a patient with meningitis. But that is easier said than done for the following reasons. And one of the major reasons is that the diagnosis of the disease is really challenging. There is no good diagnostic test, essentially. There are clinical algorithms that help identify those people who are more likely to have the disease than others, but they're not highly sensitive or specific. The CSF examination for acid-fast bacilli and culture varies enormously, and I'll go into that in a little bit more detail next, but in general is too insensitive. There are newer diagnostic tests such as GeneXpert, which again I'll give a little bit more information on, and they've certainly had a major impact, not least because they are quite sensitive, but they also give information on drug resistance, which is enormously helpful. But what we really need is something like what we've got for cryptococcal meningitis, and that's a really sensitive and specific lateral flow assay, for example, that can be done easily anywhere in the world on CSF. But unfortunately, at the moment, we do not have this. I just thought it's worth remembering that actually finding acid-fast bacilli within the CSF through the Zeal-Nielsen stain actually is actually can be very helpful. It's not in many laboratories' experience and many clinicians' experience. But if you look back to, this is a paper from 1953, actually from the United Kingdom, and by taking very large volumes of CSF, examining CSF repeatedly, spinning the CSF at high speeds and looking for a long time at the CSF under the microscope, they were able to see acid-fast bacilli in 91 out of 100 consecutive cases. And this was a method that we took to Viet Nam almost 20 years ago now when I started working here. And I read this paper and thought, right, well, can we improve the diagnostic performance of Zeal-Nielsen staining by increasing the volume and doing all the things that Sheila Stewart in the paper I've just shown you did? And we found that we could, perhaps not quite to the extent that she did, but we were able to increase the sensitivity of smear to around 60%. And that made an enormous difference to our management. And when you look at the factors that are associated with acquiring positive bacteriological results from CSF, these by multivariate analysis are the things that came out. So duration of symptoms, so the longer people had symptoms, the more likely you were to get positive bacteriology. The larger the volume of CSF, the more likely you were to get it. And then there were some other things like neutrophils and lactate and blood glucose. But the only thing that is modifiable there for physicians and for people in the laboratory is the volume of CSF. So you really do need to take greater than 5 mils, closer to 10 mils if you can, of CSF to be able to confirm by Zeal-Nielsen staining and culture Mycobacterium tuberculosis within the CSF. There's a lot of interest at the moment around XPERT, and particularly a new design of XPERT called XPERT Ultra, which is designed to be much more sensitive than the older XPERT. And this is the first study that reported the use of XPERT Ultra in the diagnosis of TB meningitis. It was done by David Bulwer's group in Uganda. It was testing CSF retrospectively with Ultra and XPERT, the standard XPERT, and it suggested that Ultra really was quite significantly more sensitive. And you can see the data on the left there, with Ultra appearing to have a sensitivity of around 70%, standard XPERT 43%, culture 43%. You'll note that there's quite wide confidence intervals for those estimates. Subsequent to that, 2 papers published very early this year in 2020, one from our group in Viet Nam and one again from David Bulwer's group in Uganda, examined the same question, but with much larger numbers of people, participants with both TB meningitis and other brain infections. And this is a summary of what these studies tell us. So just a summary of the Uganda study. There were 204 participants, 42 of whom had TB, and the majority had HIV, as you'd expect, in sub-Saharan Africa. And then in Vietnam, we had roughly the same number of participants, 205, except a larger number had TB meningitis, 99, and only 15% had HIV. And what you can see between the differences between the 2 studies, there was an important design difference in that in Vietnam we randomized people to either have Ultra or XPERT, and this is because if you did both tests on one CSF, you were you were reducing the volume and therefore the likely numbers of bacteria that you could detect whereas in Uganda they did both tests on one CSF sample. Anyway, the results from Uganda suggested a sensitivity of around 77% of ultra, so similar to their previous study, and 56% of expert. And for us in Vietnam, the sensitivity of ultra was around 58% compared with 48%. So I think the conclusion from this is that ultra is probably a little bit more sensitive, particularly actually in HIV uninfected individuals with low bacterial loads. But the important message is that neither of these tests, expert or ultra, can be used to rule out TB meningitis. It's just not sufficiently sensitive to do that. And therefore, you should never discard the diagnosis on the basis of a negative expert, be it expert standard or expert ultra. So then, just to move to the treatment of TB meningitis, there are two broad ways of tackling the treatment and improving outcomes, or three if you include intensive care, which I will. But the first is to enhance bacterial killing, and the second is to control intracerebral inflammation. And surrounding that, obviously, is improving general care of critically ill patients. So if we consider anti-tuberculous drugs, the brain is in an unusual position that it's surrounded by the blood-brain barrier, and that causes problems for certain drugs, because some drugs are unable to cross the blood-brain barrier very well, and therefore you get less exposure of that drug within the brain, and that may impact the ability of that drug to alter outcomes from TB meningitis. So what we know from the standard 4-drug treatment of TB meningitis is that isoniazid penetrates very well, as does pyrazinamide, but rifampicin and ethambutol and streptomycin penetrate poorly into the CSF. And particularly important is the limited penetration of rifampicin, because this is an absolutely key drug in the treatment of drug-sensitive disease. And people have long speculated that we've got the doses wrong of rifampicin and that you should have higher doses, and I'll discuss that in a second. But if we consider the newer drugs, if you look at the fluoroquinolones, certainly levofloxacin and moxifloxacin penetrate reasonably well into the CSF. Ciprofloxacin does not penetrate at all well, and therefore should never be used for the treatment of TB meningitis. In fact, should never be really used for the treatment of any form of TB. The newer agents, such as bedaquiline, delamanid, pretomanid, there's very little data. There's some data now emerging to suggest that delamanid and pretomanid probably do penetrate well and achieve quite high brain concentrations, and may be useful for the treatment of MDR-TB, but more data required. Bedaquiline, very, very little data. A recent paper suggested that very little, if any, appeared in the CSF. But the problem with bedaquiline is it's very sticky, and actually doing the assay is very difficult, because the drug probably sticks to tubes when you put the CSF in tubes, and therefore does not become measurable by the assay that you're using. So more information required there. So just to return to this problem, or the question around rifampicin, which is a hot topic at the moment, both in the treatment of all forms of TB, but particularly TB meningitis. And as I say, there's been a long-standing hypothesis that we're underdosing rifampicin in TB meningitis, and this was really confirmed by a small study, only 60 patients, Indonesian adults, who compared oral rifampicin with intravenous rifampicin at a slightly increased dose. And they had a remarkable effect on mortality, which you can see here. Very small trial, so I think you have to take this with caution. But the suggestion from this result was that if you used intravenous higher dose rifampicin, you got improved outcomes. At the same time as this trial was published, we were undergoing a much larger study. So this was in 817 adults, published in 2016. Which compared a higher dose of rifampicin, but not particularly high, 15 milligrams per kilogram, with the addition of levofloxacin also, comparing that regimen with a standard regimen. And that increased dose of rifampicin and levofloxacin was given for the first 2 months of treatment. And you can see the Kaplan-Meier survival curves down the bottom there, and really absolutely no difference between the two groups. And indeed, actually, there was no subgroup either that seemed to benefit, with one exception, and that was the people who had isoniazid-resistant TB meningitis. And in these people, that regimen caused less death, and that was the only really positive finding from this paper. But what we did then, and this took a couple of years, was to go back and do a pharmacokinetic and pharmacodynamic analysis of the patients from this trial, subset of patients, and look to see what the relationship was between rifampicin exposure and outcome, but also the exposure to the other drugs and outcome. So at the top table there, you can see the difference in rifampicin pharmacokinetics between the standard therapy arm and the intensified therapy at 15 mg/kg. And you can see that there's substantial increases in exposure as assessed by Cmax and area under the curve between those two treatment arms. But unfortunately, we weren't able to show any relationship at all between exposure to rifampicin and outcome. So what we did was look at the other drugs, and we came across a very surprising and interesting finding. We found that actually, if you looked at isoniazid exposure, that strongly influenced outcome. And the data that I can show you there on the figure looks at various different exposures, so Cmaxes of isoniazid. So blue being high, green being intermediate, red being low, and the probability of survival at various different Glasgow Coma scores. So Glasgow Coma score 8, those people with severe disease, 10, less severe, 14, less severe still. And what we found, and you can see that relationship very clearly, was that if you had low exposures to isoniazid, you were very strongly likely to die. And as you will probably be appreciative of, isoniazid is acetylated according to a genotypic variation, the N-acetyl, the acetylator status rather of a particular patient, and there are fast, intermediate, and slow. But when we looked at the people who died, 28 of them were in the fast metabolizer group and had lower concentrations. So we think that this is probably important and that this needs to be looked at in further detail in future studies. But moving now to anti-inflammatory therapies, it's long been considered that dexamethasone and other corticosteroid and anti-inflammatory agents might improve outcomes from TB meningitis. And indeed, all the trials that have been done to date suggest they do. And this was one trial that we did quite a while ago now, and you can see here demonstrating that dexamethasone improves survival from TB meningitis. But the question is how? And to cut a long story short, it's still very, very uncertain as to how it improves outcomes from TB meningitis and saves lives. Incidentally, it appears that dexamethasone saves lives, but probably doesn't reduce disability, and that's an important finding. But there are a number of possibilities. So firstly, it might reduce hydrocephalus. You can see the yellow arrow there indicating hydrocephalus. Secondly, it might reduce the amount of inflammatory exudate around the base of the brain, and that might have a beneficial effect. And thirdly, it might prevent things like infarction and tuberculoma development. But actually, it still remains very uncertain, and I'm not going to go into any further details, but we've done a number of different investigations to get to the bottom of this, and so far all have not indicated the clear reason for why dexamethasone reduces mortality. But the question that I think is interesting too is whether there'll be more directed and more intelligent host-directed therapies to improve outcome. And there are a number of possibilities that are now being considered. Aspirin is one of them. I'll give you a little bit more information on that in a second. Thalidomide, anti-TNF biologics, interferon gamma, all of these there are no trials in any of these agents, with the exception of thalidomide, which has one small trial which was stopped early. That was done in South Africa. But the doses used in that trial were extremely high and probably accounted for that, for an adverse profile in the thalidomide arm. And there are a number of other different candidates, which I'm not going to go into detail here, but I want to just give a little bit more information on aspirin for TB meningitis. So there have been 3 trials conducted using aspirin for TBM. The first was reported in the Journal of Neurological Sciences. This was a paper from Professor Misra from Lucknow, which randomized, I think, 118 patients to receiving aspirin or not, in addition to corticosteroids. And you can see the results of that in the panel below Prof. Misra's picture. And that shows that the suggestion that mortality in new stroke was prevented by aspirin. But this was a small study. Johann Schumann did a trial in South Africa, in South African children with high and low dose aspirin. And again, there was some soft suggestion that higher doses of aspirin seemed to improve outcomes, but it wasn't a particularly clear result. So just to consider the hypotheses around aspirin. So if you use low dose, you inhibit thromboxane A2 and the ability of platelets to coagulate, to stick together. Whereas if you use high dose, you have that ability, but you also have two other effects that may improve outcomes in TBM. That's an anti-inflammatory effect, an inhibition of the production of prostaglandins particularly, but also a newly recognized mechanism, and that's the upregulation of pro-resolving molecules, which help the resolution of inflammation. Now, both of those, well, all three of those mechanisms may improve outcome from TBM. So what we did in Viet Nam, and this was a trial reported a couple of years ago, was a phase 2 trial comparing a lower dose of aspirin, 81 milligrams, or a higher dose, 1,000 milligrams, for the first 2 months of treatment with the addition of dexamethasone. And we looked to see whether, in particular, it was safe and whether it could reduce death and infarcts in the brain as defined by MRI imaging. And again, just to highlight the key results here, because we haven't got time for much more, but what we found was that the higher dose of aspirin at 1,000 milligrams a day seemed to be safe. There was no suggestion of increased GI bleeding, for example, and may reduce deaths and new infarcts. And what you can see here are the results for those people in the 1,000 milligram arm. And I've kind of highlighted there in that sort of orangey color, the fact that if you looked at the subgroup with definite TB meningitis, so these are microbiologically confirmed, which is the majority of patients, then these people particularly seem to benefit from 1,000 milligrams. Now, this isn't enough evidence to change practice, and I don't suggest that everyone ought to be giving aspirin to all patients with TB meningitis, but it is enough evidence to go ahead and do some large phase 3 randomized controlled trials, and indeed those trials are underway. The other interesting thing is we were able to measure the inflammatory mediators in CSF, including lipid mediators that might be influenced by aspirin. And we found indeed they were. So you can see thromboxane B2, which is the stable metabolite of thromboxane A2. You can see that was dose-dependently inhibited by aspirin. Likewise for prostaglandins. And then you've got this upregulation of these very interesting pro-resolving molecules, the protectins and the merasins. And again, this in the CSF, you can see the upregulation of these molecules. And my instinct at the moment is that these are probably going to be important to the pathogenesis, the impact of aspirin on outcome, but further work needs to be done to confirm that. So the last part of my talk is just to highlight the importance of neurocritical care and of those with TBM. And so this was a review that we wrote recently, published in Neurology, and I encourage you to go further into this review. But just to underline or highlight the main issues here. So this is concerning the management of hydrocephalus, hyponatremia, the management of paradoxical reactions that we all know are difficult and can be common, and then the best and active management of raised intracranial pressure in this disease. These are all difficult issues. There's actually very, very little evidence to define what is best to do. But I think in terms of improving outcomes from TBM into the future, aside from improving anti-TB drug therapy and improving adjunctive agents, this aspect is incredibly important. It's multifaceted, not going to be one thing or another. It's just about providing really good clinical care. But what we need to do is to acquire some better evidence as to how to manage these particular problems. So the last thing to note, I think, is there is a TB International Research Consortium, which has been going since 2008. Our first meeting was in South Africa. Our second meeting was in 2015 in Viet, in Vietnam, and you can see the photo there. And then we had a meeting last year in Lucknow, which was a really successful and happy event. And actually, in good timing for this talk, last night, we had an online meeting of the consortium, because obviously we can't meet in person because of COVID. And at one point, nearly 185 people joined the meeting to listen to the various talks that were given on TBM. So there is a thriving research community now around this disease. and there's a lot more work being done. The consortium has published a series of review articles which you might like to look at in Wellcome Open research. I'll give you the link there. And those are review articles written from authors around the world about the various difficult clinical problems and how we might tackle them. So I really encourage you to look at that resource for those of you interested in this disease. Lastly, as I said, there's a thriving research community now, and there's a number of really big trials going on and being planned. Just to run through these, because these are going to produce results sometime in the next 2 to 3 years. There are 2 big trials we're conducting in Viet Nam. One is the use of steroids for HIV-infected TB meningitis. This is a trial that is close to completing. We've randomized close to 500 patients out of 520 anticipated. So we should get results from that in around 18 months' time. We're doing a trial where we are randomizing HIV uninfected patients stratified by the LTA4H genotype. I don't have time to go into that now, but this is a gene that seems to appear and may determine responsiveness from steroids. So that's a trial of 720 adults. We're again about 500 into that. There is a TBM kids trial, part of which is conducted in India, and actually we heard about the first preliminary results from that trial yesterday evening. This is looking at higher doses of rifampicin and levofloxacin in kids. There's a couple of trials of higher doses of rifampicin, small trials. There's the RIFTY study in Uganda and the laser trial in South Africa, and a higher dose isoniazid trial in fast acetylators in Beijing, which we're very interested in. And then there are a number of planned trials, many of which are looking at higher doses of rifampicin in particular, and also the addition of aspirin. So really exciting times ahead, I think, for this disease, with lots of ongoing big clinical trials. And with that, I think I'll finish. I'd like to acknowledge the TB group in Okra, Vietnam, who've led a lot of this work over the last 20 years, and particularly Dr. Tung, who is the lady in the top left-hand corner there. She leads the group for us at the moment in Vietnam. It's been a pleasure doing all of this work, and it's a shame that I haven't been able to visit CMC Vellore again because of COVID, but I very much look forward to doing so in the future. And I thank you all for listening, and I look forward to answering your questions on the night of this conference. So thank you all very much for listening.